Um, the concerns we have about this, it's only been around for about 5 to 6 years, and the retreatment rates start to creep up at about the 5-year mark. So if you look at the current studies, at 5 years, about 25% of patients have either gone back on medication, needed another procedure done, or needed a TURP, or there's encrustation of those implants. So we're still concerned a little bit about how long will this last? Are you going to need a tune-up procedure done 5 years later? The other procedure that I wanted to mention to you is one called Resume. And Resume is actually something I was lucky enough to bring to Sutter Health and to Palo Alto Medical Foundation. Resume is based on the idea that you can inject steam or water vapor in 9-second injections into the prostate. And by doing that, it will go ahead and shrink the prostate. The injection is done under some sedation, again in the surgery center. It's about a 15-minute procedure and patients go home the same day. Why is this beneficial? Well, number one, you do see symptom improvement with this because what the steam does is it actually causes the prostate tissue to regress and open up that channel so you have a wider channel to urinate through. It doesn't require a general anesthetic, and it preserves both sexual function as well as urinary function. I've done over 200 of these. I can tell you we have no cases of new erectile dysfunction and no cases of urinary dysfunction. So patients who are very active, working, younger, they like this because it doesn't affect those aspects of their health and they can go back to work fairly quickly. What does this look like before and afterwards? So I was talking about something called the median lobe. So here we are in the urethra right now, and this is looking into the bladder. The little black sliver you see over here, that's the bladder. We have a camera perched inside the urethra. And do you see this big monstrosity in the middle with all these blood vessels? That is enlarged prostate tissue. That is what we call a median lobe. When this man tries to urinate, this tissue basically blocks the flow off. So this gentleman was treated. We treated the median lobe with the Resume procedure and treated the sides. This is what it looks like 6 months later. Open channel. And his symptoms dramatically improved. He's actually one of my patient spokespeople for Resume. They're the ones who are like, if anyone wants to talk about it, I'll be happy to talk to them because he had such a dramatic improvement in his symptoms. So Resume is a really nice option. Now, what are some of the caveats? So here's some of the data from the studies. You can see that their symptom scores started out at severe and came down to mild to moderate. And their flow rates went up from 10 all the way up to 16, seeing a little bit of drop off here. And I'll tell you that we are seeing some recurrences as the prostate does regrow, with about a 15% chance that you're going to need to go back on medication or on have a retreatment. So lower than UroLift, but still seeing some retreatments out there. These are more quality of life indices that also look favorable as well too. So 10-minute procedure. 15-minute procedure done in the outpatient surgery. The one downside is you need a catheter for about 3 to 4 days, and that is pretty bothersome. I will say that that's a downside, but you can see symptom improvement 6 to 8 weeks afterwards. We've been very excited about this for the proper patient who wants it done. It's been very, very good overall. All right, I'm gonna briefly cover in about 5 or 6 minutes PSA screening, and then I'm sure there's gonna be plenty of questions on this. PSA screening, well, this started back in 1992, so actually almost 30 years now. And there was an enormous increase in the number of prostate cancer. Everyone got a PSA. If many of you remember, like you go to a football game and there would be a van outside and they would get you a PSA done at that time and do a prostate exam. It was crazy. But we weren't selective about who was treated. And so now we're really confused about what we should do. Should you get a PSA or not? When do you get a PSA? Well, what did work? When we did do PSA screening, it dramatically reduced the number of men with metastatic disease. Before PSA existed, 21% of men presented with metastatic or advanced cancer. After the PSA era, only 4%. The number of deaths from prostate cancer declined dramatically. You saw much less metastatic disease. For those of you who trained in the days before PSA screening, you remember the guys coming in with bone scans littered with metastasis. You just don't see those cases that often now. And you see that the death rates decline dramatically. Prostate is labeled here. You can see that the rates, these were the rates of cancer here. And then after we started screening, the numbers came down. Unfortunately, screening rates have gone down, and we're starting to see an increase in the rates of cancer. So the problem is that we weren't very selective. We biopsied everybody, we treated everybody, and there were a lot of side effects from treatment. I'm sure all of you have had patients who have had surgery or radiation, who have incontinence now, erectile dysfunction, surgical complications, or radiation complications. And we basically state chairmen of the department were built on the fact that they operated on everybody. A guy named Pat Walsh operated on everybody at Johns Hopkins. Careers were made on fixing these complications as well. So because of all these problems, the US Preventative Services Task Force, the national group that talks about screening, basically said, you should not screen. They came out with a D grading for prostate cancer screening, and they used it on really bad data, okay? I will tell you that. This was a bad recommendation by them because they used bad data. Well, what happened? Everyone looked at this and screening rates dropped dramatically. We also saw a decline in the number of prostate cancer cases as well. They declined dramatically as well. So here you go. Here is where these graphs represent the rates of screening for different age groups. And you can see that in 2005, the rates were much higher here. And then in 2013, the rates of screening went down dramatically afterwards. Of course, when you screen less, this is data from Kaiser, a friend of mine who published this paper. Look at the rates of screening after that recommendation. In every single group, the rates of screening went down, including the highest risk groups like African Americans. Unfortunately, what happens next? Metastatic disease starts to go up, particularly in African Americans who are at highest risk for prostate cancer. So you're seeing this increase in metastatic disease now, and that's been verified in a number of papers because people aren't screening. So the problem with the recommendation from the US Preventative Services Task Force is they use bad data. If they just use a large trial from Europe, it shows you that if you get PSAs in properly selected patients, you will decrease the risk of prostate cancer death by 20%. Decrease risk of death by 20%. However, if you use bad data, like the trial done in the United States, see a difference. The problem we had in the United States was they had a trial where half the men were supposed to get a PSA and half the men weren't. Well, the men that were told not to get a PSA, guess what they did? They went and got a PSA anyways. So even though they were not supposed to get a PSA, 85% of the men had a PSA done anyways, because you're comparing basically the same thing. So that didn't work very well for a study. So ultimately, if you look at the data from the European screening trial, you will reduce the risk of death from prostate cancer by 20%. And you basically need to treat 18 men to avoid one cancer death, which is as good as mammography is out there right now. So that recommendation about PSA screening has changed. And now the guideline is that men between 55 and 69 years old should be screened or should have a discussion. Men should have the opportunity to discuss the benefits and harms of screening with their clinician and incorporate their values and preferences. Here are my thoughts. Not everyone should get a PSA. You should probably start at around age 50. I think that's a practical age, and it actually is where we can see prostate cancer, particularly in the United States. A man should have greater than a 10-year life expectancy. And for men between the ages of 40 or 45, or if they have a family history, for African-American men or men with a family history, you should start screening at age 40 to 45. Again, African-American men or men with a family history, first-degree relative, age 40 to 45. You should stop PSA screening when someone has less than a 10-year life expectancy, but that's a highly variable number. I mean, I have 75-year-olds that are swimming 5 miles a day. Who am I to say that they are not going to be living 10 years from now? And we have a discussion about whether we should get a PSA or not. I have more on PSA, but I want to yield the floor to my distinguished colleague, Savitha Krishnan. So I'm going to stop there and look forward to our Q&A and can answer more questions about PSA screening and other things for you in a little bit. So thank you for your time and look forward to the Q&A session.
Thank you so much. That was really informative. And the great thing about Raj is he treats men and women. So part of my talk can all go to our urology department. Urogynecology really just, can you guys all hear me okay? Urogynecology, let me just share my screen. Yeah, perfect. So urogynecology really just sort of focuses on urinary incontinence and prolapse. So I wanted to go through kind of how prevalent this condition is and how many treatment options we currently have and how this impacts the quality of life for a lot of our patients. So I'll start with urinary incontinence, and then if I have time, I can absolutely get to prolapse also. So if you look at urinary incontinence, we have a couple different types of urinary incontinence. And when patients come into my office, I try to really differentiate with them what type of urinary incontinence we have so that we can tailor our treatment options to their type of urinary incontinence. So the main forms of, if we kind of start with the prevalence, 1 out of 2 adult women have some type of urinary incontinence. And so my background is I practiced OBGYN for 13 years. And then I transitioned over to urogynecology for the last 9 years. And the year I transitioned over to urogynecology was the year I really started public speaking about the awareness of the prevalence of this condition. And that was the year that Johnson & Johnson sold more adult diapers to women than they did to infants. And so I know if you kind of watch TV, you see all these different commercials about how we have attractive underwear for women in terms of their bladder leakage. And it kind of just really made me feel for these women when we do have some great therapies that are out there that can solve this condition or at least improve this condition for them. So 1 out of 2 women. So one of the Medicare screening questions actually is, do you have incontinence? And the reason why that question exists is that it actually affects the quality of life for so many women, particularly urinary urge incontinence. It becomes a socially debilitating condition, and a lot of patients actually become socially isolated because of how serious of a condition this is. They have a lot of anxiety just going out. So if you look at that, that's 18 million women. And if you look at all the new startups and companies, this is a huge volume for them to approach because there's so many women that have this condition. So if we look at the most common types of urinary incontinence, right, it's really divided into urge urinary incontinence, which is more of dome of the bladder. And that goes along with Dr. Shingal's talk about prostate issues. And this is why I don't touch men, because I do not know that anatomy very well. I send them all to our urologist. But urge incontinence, a lot of these men with prostate issues are going to mimic the symptoms that a woman might have with urge incontinence. And we as women have our own issues of prolapse that can cause urge incontinence that I'm going to touch on. And then our second form is stress urinary incontinence, which I'll go over what kind of those common symptoms are for stress incontinence. And then a lot of women have mixed incontinence, right? That have stress and urge incontinence. And what I really try to do with them is divide that out. I have 2 different pamphlets that go out with stress and urge, really give them the treatment options so that their expectations of the outcome is really intended for the disease or the state that we're treating. So if you look at this, this is sort of how the division is, that a lot of women have stress incontinence, about 22% of women have urge incontinence, and about 29% of women have mixed incontinence. So if you look at urge urinary incontinence, right, this is your woman that's going to come into the office. And this is the one actually that's most anxiety provoking. This is the one that a lot of our elderly patients get institutionalized for because it's tough to take care of this, because this is not a couple drops of urine leakage. This is the entire dome of the bladder contracts and they have a large leak. So these are women coming in where they're avoiding 8, 10, 12 times a day, totally disruptive to sleep. They're waking up 2, 3 times at night, depending on how much pelvic strength they have. As soon as they feel that urge, they've got to beeline it over to the restroom. Otherwise, they're going to have an accident, right? So this is something that really we try to hit on. And a lot of times it's very interesting when patients come in, they're kind of sometimes told that this is a normal process of aging. Although it's very prevalent in aging, it's not quite normal, and we can offer some options. And all of our options are not significantly invasive. Like some of them are just dietary, right? And I'll talk about some of those dietary, bladder training, physical therapy options, because we try to start with our conservative options first, and then step it up to the more maybe effective treatments, but a little bit more involved treatments. So these are women that are going to come in and they're going to say, I have a strong desire to urinate. As soon as I feel that desire to urinate, I have a hard time getting to the restroom. I'm woken up in the middle of the night frequently to go to the restroom, and I know where all those restrooms are, right? I go to the mall, I know every single restroom on my route. These people have a difficult time traveling because of their urgency. These people, a lot of times it's billed to me out as urinary retention because they empty their bladder, then they feel like they need to sit down again and empty again. So they feel like they're not emptying their bladder well, right? And it's really truly not urinary retention, although some might be. It's really that their bladder is contracting again, even with a lower volume in it than someone without this condition. So I try to educate them as to that it's really not retention. And if we get your overactive bladder symptoms better controlled, you won't perceive that need to go to the restroom after you void. Yeah. Okay, so stress incontinence is on the other flip side of it, is the leakage of urine with coughing, sneezing, jumping, exercise, right? And I present it exactly like that to the patient. It's as pressure hits the pelvic floor, that's when the leak occurs. When the pressure stops hitting that pelvic floor, the leak is gone. That's pure stress incontinence, right? And so these are women that are typically have had babies born vaginally, or as we get older, it's interesting, stress incontinence kind of equalizes even if you've had a C-section because the pelvic floor sags a little bit. Stress incontinence is an anatomic issue. It's support of the anterior vaginal wall underneath the urethra. So as pressure is hitting that pelvic floor, that front wall does not have enough support, and you get that couple drops of leakage that occurs until it hits that front wall. So people will come in and say, when I run, I leak urine. So I've had a couple patients that have stepped it back and they're now doing yoga and Pilates and, to lower impact exercises. And that's one way of taking care of it. But if you really like to run, we want to get you back to running, right? Because there are some really effective treatments and a lot of office treatments for this that some newer bulking agents have come out that I'm going to discuss that are done in the office that have a little bit more effective treatment options than our traditional bulking agents. So I'll go over the treat. I think I'm having a difficult time moving slides forward. Oh, here we go. Maybe let's go back. So yeah, let's go forward. Okay. So two types of stress incontinence. There is the hypermobility, which is the more frequent kind of urinary incontinence. That's that front wall supporting the urethra. And then we've got intrinsic sphincter deficiency. And sometimes this is a little bit of a spectrum. We used to do a lot of urodynamics to evaluate the form of stress incontinence. And a lot of our options really treat both of these. A lot of our retropubic slings, which I'm going to talk about, do treat intrinsic sphincter deficiency as well as hypermobility. They will both present with that leakage with coughing and sneezing. Intrinsic sphincter deficiency is a much more severe kind of condition where they're constantly leaking even at lower volumes. These are our risk factors for stress incontinence. So it's really pregnancy and vaginal childbirth. It's that relaxation, anything that's going to cause increased pressure on that anterior vaginal wall, whether it be you're really heavy, you've gained a lot of weight, you're chronically constipated, you've had a hysterectomy, and there's some relaxation, vaginal deliveries. For mixed incontinence, this is that third form, and it's really a combination of the stress incontinence and the urge incontinence. And what we really want to kind of work with them, although we have therapies for both, is which one is really bugging you. And if you look at most people coming in with mixed incontinence, it's the urge that's really bugging them, right? We can treat the stress incontinence, but I like to treat one at a time. Otherwise, it gets really confusing for a patient to really know what the expectation of that outcome should be. Next slide. Let's see. Are you able to advance the slides? Let's see here. No?
You might have clicked on the Zoom window by accident. You may want to click on your app for your slides, and then you might be able to advance.
Oh, there we go. Yeah, perfect. Thank you. So we've got barriers to treatment, right? So Less than 50% of women that actually bring up that discussion. So if you look at women, there's a lot of times they'll bring up all the other things, but because this is such an embarrassing condition for patients, I think unless we ask about these symptoms, a lot of people don't bring up these symptoms. So, but if we ask, a lot of people see that as an open avenue, and they'll start discussing how much this impacts their quality of life. So treatment options. So if we look at urge urinary incontinence, we always like to start with the conservative. And so when patients come in, I give them a treatment algorithm that they come into the office. And the only reason I give them that treatment algorithm is as I want them to come back. So if you look at women and we talk about lifestyle changes and physical therapy, we know that caffeine, alcohol, carbonated beverages really irritate the bladder. We do have some oral medications that we can try. We've got your traditional anticholinergic medications that sometimes can cause some dry eyes, dry mouth, and constipation. We have our beta-3 agonists, and we actually have 2 beta-3 agonists now on the market. So if one's more expensive than the other, we can go to the other one. But if you look at women, if you give them a prescription for a medication, there is a pretty high chance that they're not going to take that medication, right? And, the data shows that 60% of patients after the initial prescription that's given to them don't come back for a follow-up appointment, right? Despite all of our education. So what I really try to tell patients is I share that attrition rate with them and I share their frustration with them. And I try to portray all of the options that we have. So when a patient comes in and they know that that medication doesn't work or they don't want to take a medication, they're coming back for that follow-up visit so we can talk to them about other options. And we actually have 3 other options, right? So we start with physical therapy, bladder training, dietary modifications, not drinking as much at night, sort of some behavioral options, the oral medications. But if those don't work, we have 3 other office options. One of them is Botox. And the great thing is our urology departments actually offer all of these services. So we have offices that are probably close to your patients across the bay that we hopefully can help them with, because some of these are repetitive treatments. So we've got Botox. So Botox is an in-office procedure, and essentially patients will come in, we'll put a little bit of lidocaine into the bladder, we'll let that sit for 15 minutes, and then we'll put a small scope into the bladder and we'll just inject usually 100 units, sometimes 200 units of Botox into the bladder. Office procedure, local anesthesia, 15-minute procedure in the office, maybe 30 minutes total. Patients drive themselves here, they drive themselves home. So it's a great option, especially for those older patients that have really bad incontinence, and it has a 90% improvement rate. Lasts for about 4 to 6 months. And the risks really are urinary retention and sometimes a slightly increased risk of urinary tract infections that we can help them manage, but those rates are incredibly low. So that's a great in-office option. We've got a second great in-office option, which is tibial nerve stimulation. This is where we put a little acupuncture needle behind the ankle and we stimulate a nerve called the tibial nerve. We do that once a week for 12 consecutive weeks, 30 minutes at a time. And after 12 weeks, about 72% of patients will see an improvement in their symptoms. And then in our office, we see them actually back once a month. And, I think a lot of it is they also meet with our nurse and they talk to them about the caffeine and the dietary management. So that probably plays a role in their outcome. But we do a ton of tibial nerve stimulation in our office. And then the last option, super excited to talk about, is sacral nerve modulation. So the third sacral nerve innervates the entire pelvic floor. So we have an office diagnostic procedure where a patient will come in, they'll lay prone on, and we essentially just clean off their lower back with betadine or Hibiclens. We place a little fine wire by the third sacral nerve percutaneously, local anesthesia, quick procedure, 15 minutes in the office, by the third sacral nerve on the right, third sacral nerve on the left. They're then wearing a little belt that has an external battery in it that delivers energy to those little wires. And we place the wire on a Thursday, they come back to the office on Monday. Within that 4-day period, 85% of women will see a significant improvement of urinary urge incontinence. And it's also the gold standard for fecal incontinence. So 90% of women will see a benefit of accidental stool incontinence. So after they see that benefit, they buy into the therapy, and then it's a quick surgery center visit, and it's IV sedation and local. None of this is general. It's a 40-minute surgery center procedure, and they go home same day, right? So the benefit of actually putting in an implant that's going to actually deliver energy is now there's a battery that actually has a lifetime battery life of 10 to 15 years. That's out with Medtronic. So there's a competing company that has a similar battery. But so they actually get to see the benefit of a diagnostic test in the office. And I usually just invite their spouse or their family member to be in the room with them. So it's really a low bar to try the therapy. And then if they see the benefit, then we move on to the actually implant, which gives them great benefit long-term. Okay, shifting to stress incontinence. I know it's a whirlwind, so I'm happy to take any questions at the end of the session. So stress incontinence is, remember, is that leakage with coughing, sneezing, jumping, exercise. Our goal is to give you support underneath the urethra, whether it be with Kegels exercises, pelvic floor physical therapy, to teach you how to do the Kegels exercise appropriately. We've got vaginal pessaries that have a little knob on the front of them that go into the vagina, and that little knob sits underneath the urethra to give you that backstop when you cough or sneeze. Great option for older patients. We've got injectable bulking agents done in the office. So we have like a slew of bulking agents with really the same efficacy. In January 2020, a new bulking agent came out from Europe on the market called Bulkamid that has had slightly better efficacy. And this is an office procedure, local anesthesia. We put a small scope into the bladder, back it off to the neck of the bladder, and inject a bulking agent on the inside of the urethra, tolerated in the office under local anesthesia. Patients are walking out the same day. Not as effective long-term probably as our tension-free mid-urethral slings, but a great option for a patient in the office. And then we've got our tension-free mid-urethral slings, right? So this is a tiny strip of mesh that we make a 1 centimeter incision on the the front wall of the vagina. We add a sling underneath the neck of the bladder. So when people cough, sneeze, jump, exercise, they've got support underneath the neck of the bladder. Great thing about this, office procedure. It is a light general anesthetic, but patients are going home the same day. 89 to 94% success rate lifelong for stress incontinence. So a great long-term procedure for leakage of urine with coughing or sneezing. And then the other options that we have are a little bit more invasive. So I finished training, like you heard, 22 years ago, and this is what I was doing 22 years ago, Birches, these more invasive procedures. And although they have their role nowadays, we do them very infrequently because the bulking and the tension-free mid-urethral slings have done such a great job. So mixed incontinence, again, we just kind of figure out which one's bugging them the most. And usually it's the urge, but we kind of try to address the one that's bugging them the most and then address the other one subsequent to the procedure so that they don't get the therapies confused. Yep. And then who will, let me see if I can get rid of that. Is that in the middle of the screen? Do you see that in the middle of the screen? Yeah. Hold on, let me see. I can get rid of that. Okay, there we go. All right. So who can really treat this? And it's really all of us, right? So urology treats a lot of these conditions, and we have a great team of urologists that we work with. Urogynecology treats a lot of these. Some of the benign GYNs also do treat some of these. So I think the best thing a patient can do is, as primary care physicians, is just increase awareness, ask the question of, do you have issues with leakage of urine? And get them kind of to someone that's going to maybe offer them a lot of these options. Because I think as long as we open up that discussion and say, hey, it's okay to talk about this, it's a common condition, although it may be embarrassing for them, we really want to make it as common as possible, because there's so many women that suffer from this condition that I think we can reach out to and help. So I usually tell my patients, if the sling patients and the urge incontinence patients, spread the word, start talking in groups to try to increase the awareness of the therapies, because I think a lot of people have a negative impression of how invasive those therapies used to be and how ineffective those therapies used to be with multiple side effects, that they're really not aware of all those office-based procedures that we currently have. And then, I don't know, let's see, it's 7:49. So I've got some slides on prolapse. Happy to share them if you guys feel like you want to go talk about prolapse. But I kind of run out of my time. So wanted to kind of gauge the situation. The prolapse talk is about 10 minutes. Do you want to go there, or do you want to just go into the question and answer session?
Go ahead,
Please
Savita.
continue. Please continue.
Okay.
Keep going.
All right, so let me go into the other session then, share screen. Okay, so we've got pelvic organ prolapse, right? And as urogynecology, we treat a lot of pelvic organ prolapse. Let me start here. Okay, so let's get this as a center screen. Yeah, so pelvic organ prolapse. And again, I'm happy to take questions at the end because I'm going to kind of go through this quickly to value your time. Pelvic organ prolapse is really, we've got the uterus at the center, the bladder that sits on the front wall, the front of the vagina, and the rectum that sits behind the uterus. So we've got 3 different compartments of prolapse that can occur. The uterus or the apex can come down, the bladder can push on that front wall of the vagina, and the rectum can push on that back wall. So if we look at treatment options of, here's sort of a picture of the anatomy. So we've got the uterus right here, the bladder sitting on that front wall, the rectum sitting on that back wall. And pelvic, yeah, pelvic organ prolapse really affects a ton of people, right? And the majority of people that have pelvic organ prolapse, again, have similar risk factors as stress urinary incontinence. Usually it's vaginal deliveries, large babies born vaginally, definitely forceps deliveries, vacuum assisted deliveries that cause a significant increased risk of prolapse. Being heavier, having chronic pressure on that pelvic floor causes a lot of issues with prolapse. So if we look at sort of potential causes, we know that, you know, babies born vaginally, right? So if you look at someone's history, 2, 3 babies born vaginally, we see a lot of Indian women actually that have prolapse, and they've been looking at sort of collagen types and genetics in terms of the increased risk of prolapse. And there definitely is an increased risk of Asian Indians and Asians with prolapse. And they're looking at different collagen subtypes as to why that occurs. But essentially a patient will come in and say, I've got a bulge that's coming out of the opening of the vagina. I may not be emptying my bladder well. I may not be emptying my rectum well. Typically pelvic pain is not a symptom of prolapse. So I'm very leery when patients say, I want my prolapse fixed because my pain is going to get better, because we have people that have complete uterine prolapses that have no pain whatsoever. Right. So we've got multiple options for prolapse. If you look at the options, they're really based on the type of prolapse that they occurs, right? So this is a cystocele. So this is the bladder pushing on that front wall of the vagina, right? And we grade prolapse in 4 stages. So as long as it's within the vagina, it's usually a stage 1 or stage 2 and can be treated by a simple outpatient procedure. But Stanford published pretty significant data that shows that when the prolapse starts bulging outside the opening of the vagina, it's not just in the bladder or anterior compartment prolapse, it's the uterus that's dragging everything down. So if you don't do something to suspend the uterus or get the top of the vagina up, the prolapse is going to recur. So we've got the bladder pushing on the front wall. This is a picture of someone that's had a hysterectomy. And now the top of the vagina is starting to bulge out. And eventually that will drag the bladder down with it. That will drag the rectum down with it also. Here's a picture of a rectocele. So we have the rectum pushing on that back wall. This is a really common prolapse for someone that's had large babies born vaginally, because usually the hit for the vaginal delivery is that posterior vaginal wall. This is someone that has an isolated enterocele, pretty uncommon in terms of just a little defect on that apex of the vagina. And so how do we treat this, right? And, you know, a lot of people, it's very interesting, are very fearful to come to the physician because they think surgical options are the only thing we're going to present. So we have a ton of options for pelvic organ prolapse. If it's an early prolapse, physical therapy does a great job. So we have pelvic floor physical therapists across the bay to help us, and they do a great job of really teaching a woman how to do Kegels exercises appropriately. The data is pretty dismal in terms of if we tell a patient how to do Kegels exercises, we even show them how to do it, probably about 40 to 50% of patients are actually doing it as well as they could. So getting them into a pelvic floor physical therapist really helps strengthen that pelvic floor and give them their best shot of a conservative therapy for pelvic organ prolapse. But outside of pelvic organ prolapse, we've got pessaries that can help support things. So we've got a lot of older women that we put a pessary in. A lot of times their dexterity becomes impaired as they get older, and we actually see them every 3 months. We take the pessary out, clean it, and put it back in for them. So it's a great conservative option for pessaries. And then we've got surgical options, and we have some pretty less invasive surgical options. If a patient's really heavy, I do counsel about weight loss because decreased weight on the pelvic floor does help. And if we do operate on patients, having less weight on that pelvic floor decreases the risk of a recurrence of pelvic organ prolapse. So pelvic organ prolapse can be approached vaginally. It can be approached laparoscopically. It can be approached with mesh, without mesh. So we go through all of these options with a patient because I think each patient is individual and different things are going to ring well with some patients and not with others. You know, we have some women that are in their 80s that are never going to be sexually active that come in with a huge prolapse. Closing the vagina actually is a great option for them. That is a 1 hour procedure. It can be done under a spinal. It doesn't even need a general. It's an outpatient procedure. They're going home the same day. So there's a lot of really minimally invasive options with great data-driven outcomes. This is just showing you kind of a synthetic graft versus native tissue repair that can help treat our patients for prolapse. So I would say just, again, talk to them about these symptoms, because I think a lot of women, even if the prolapse is pretty significant, they've either been living with it for a long period of time and it's kind of just sneaking up on them, but they don't realize that we have some really, really good, less invasive options. So none of these options require an inpatient stay. All of my prolapse patients go home same day. And they're really functional afterwards. So if you look at someone with closing that vagina in an 80-year-old, they're taking just ibuprofen or Motrin. So the pain requirements are really minimal after a lot of these minor surgical procedures. And we also have a lot of uterine preserving procedures where patients don't want a hysterectomy, and we can take that uterus and we can elevate it and we can tack it up there for them and fix their prolapse. So a lot of really great minimally invasive options. Thank you. Sorry about the speed, whirlwind. So happy to take any questions that you guys may have.
Yeah. So I had a question, and Dr. Shingle actually gave me the answer that the PSA screening does get affected by these drugs, finasteride and dutasteride. So there must be some correcting factor, because as a primary care, if I screen, then what am I supposed to do next?
Yeah, thank you for bringing that up. And I usually have a slide in there, and I removed it just for the interest of time. But if you have a patient who's been on finasteride or dutasteride, brand name for dutasteride used to be Avodart, those drugs shrink the prostate down, but they also artificially reduce the PSA by 50%. So therefore, you must double the PSA. Publication in JAMA that showed that because people don't recognize that artifact change, you underestimate the PSA, and it leads to a delay in diagnosis in prostate cancer.
Yeah.
I wish our lab reports would like mark this. I mean, we use Epic, and even Epic doesn't mark the fact that you have a patient who's on these drugs, and you should incorporate that. I've been trying to work with our IT team to solve that problem because it's an important one. Also for younger men or middle-aged men who are on Propecia, the 1 milligram dose of finasteride, that will also reduce the PSA by 50%. So you must interpret that PSA appropriately in that regard. Great question. I received another question in the chat that I'll cover. Dr. Misra, an esteemed urology colleague in the Castro Valley area, asked about a procedure called prostate aquablation. Also had those slides, but didn't include them. So as you can tell, there's a lot of different ways that people go after prostate enlargement. Prostate aquablation is yet another procedure that you can use particularly for some very large prostates. What does it do? Has anyone ever seen those water jets that they use to like slice produce or even like slice through concrete? They're really high, like 6,000, 8,000 pounds per square inch water jets. I mean, they'll cut through concrete or something like that. So these water jets, you can actually put a device that has this water jet mounted on it, take a map of the prostate by ultrasound, and then program the water jet to remove that enlarged portion of the prostate. It's a robotically controlled procedure, takes about 45 minutes to an hour. I've done a handful of procedures. It's really nice because it removes a large amount of prostate tissue very, very quickly. Traditionally for TURP and some of the other procedures I talked about today, you can get to about 80 grams on the prostate size. And once it gets bigger than that, it's really hard to do those procedures. Aquablation, I mean, there's reports of people doing 350 gram prostates, which is just massive. I mean, that's a massive, that's a grapefruit, for goodness sakes. And so the aquablation can ablate this tissue very efficiently. Now, the downside with it is that a water jet does not establish hemostasis. So the problem you run into is that those patients can bleed and you have to stop the bleeding. But the nice thing with the robot, you can program things very specifically to preserve ejaculation. So I've done a handful of these. All patients have preserved ejaculation and they've done very well. And so this is a new tool in our armamentarium in terms of taking care of BPH and trying to come up with more minimally invasive solutions. So I wanted to just address those a couple questions that were in the chat after my portion of things. Yeah, are there other questions for Dr. Krishnan? And I have to just one thing about Dr. Krishnan, I just have to tell you, like Dr. Krishnan started the urogynecology program at PAMF de novo. There was no such thing 6-7 years ago, and she's building this incredible department. She's expanded the access to care for women to take care of these problems and really brought a lot of awareness. And I just want to thank her and congratulate her because she's kind of done it single-handedly and now hiring partners and really done a great job with her. So your patients are going to be in incredible hands if they see Savita. I can promise you that.
I had a question from Dr. Krishnan.
Yeah.
The slings, I was told that they eventually get loose and need to be tightened again.
Yeah, so it depends, I think, on a bunch of different things. We have 3 varieties of slings that we have. So we talked to them about the 3 different varieties. There's different materials that are used. There's, some biologic materials, some synthetic materials, but really a retropubic sling, the synthetic midurethral sling is really supposed to last a lifetime. So I think I do 20 to 25 slings a month, and I've been doing a good volume for the last 22 years. We see some people that leak urine, and those people can have that office procedure, that urethral bulking in the office that can actually just augment that. But the majority of patients do great with the sling. I mean, it's supposed to be a once in a lifetime intervention for stress incontinence.
What about effect of age in the sling getting loose?
So it's interesting. A lot of people that come in and they think that their sling is no longer working. And if you really delve into their symptoms, their sling is working great, but they have some urgency. And as they get older, they leak before they get to the restroom, and that urgency increases because we know that urgency as you get older. So the prevalence of urgency at the age of 50 is about 15%, but 70 to 80, it's almost 50, 60%. So if you really kind of get the urgency well controlled, they then come back with the perception that their sling is working well. So it's kind of really going into those symptoms. But I definitely have had some women where we've put in a sling and then they've lost a tremendous amount of weight. And in that case there, we had to redo the sling or bulk in the office because the sling did get a little bit looser. But those were people that had bariatric surgery and lost tremendous amounts of weight. The routine patient really, so the success rate is 89, 94% of patients work lifetime. And they follow that for 18 years of data that they published. So it's actually pretty long-term data in terms of that midurethral synthetic sling. So it's interesting. It came out in 1998 and it rapidly took over the Birch. It came out like the second year of my training, and the Birch was an open procedure or laparoscopic procedure where we'd come in and we'd put stitches in the vagina. And there's some guys that are still doing a ton of Birches, but it was a lot more invasive and a lot less effective than the midurethral sling. So that's sort of become the gold standard in the United States.
So what is at the moment best material for sling?
So it's a lightweight polypropylene synthetic mesh. And the goal behind that is it doesn't get infected, it doesn't get rejected, it's super lightweight. So there were some bad actors on the market. There were the denser meshes and they got rejected and infected and there wasn't good tissue ingrowth. But the goal is it's a very light netting. And essentially the goal is that your body comes in, acts as a scaffold, and you create a new ligament of support underneath the urethra. So that way it doesn't get rejected or infected. The exposure rates are really low. I mean, almost all of my patients, I have them use a little bit of vaginal estrogen cream if they're really atrophic to thicken up that vaginal wall. And anecdotally, it's decreased the risk of mesh exposure. But I think the mesh exposure rates that we see are less than 2%. They're really low. And the thing is if there is a little mesh exposure, it's super easy to treat because it's a tiny surface area that's actually in contact with the vagina. You know, a lot of women come in and they say, mesh got taken off the market, mesh got banned. Why are you still using mesh? And That was a transvaginal mesh, right? And that got taken off the market in 2012. And it's so interesting because it's the exact same mesh that we use, but the surface area that's in contact with the vagina is very different as a transvaginal mesh for prolapse. So with transvaginal mesh, you were making a large vaginal incision, putting a sheet of mesh in, and then the entire surface area was in contact with the vagina. So the mesh exposure rates were 10, 15, 20%, and they were tough to deal with. Versus a mid-urethral sling, you're making a 1 centimeter incision. The majority of the mesh is in the space of rest is behind the neck of the bladder, so not near the vagina. And I think that's why the risk of complications is so much less.
So the mesh, is it placed differently for bladder leak or prolapse of uterus?
Yes. So it's placed underneath the urethra or the neck of the bladder for the sling for stress urinary incontinence. And for prolapse of the uterus, if we use mesh, a lot of times we just use the patient's own ligaments. But if we use mesh for the uterus, we actually don't place mesh through the vagina anymore because of the mesh being taken off the market and the increased risk of complications for prolapse. We come in laparoscopically. And we apply the mesh in a different plane. So we dissect the bladder away from the front wall of the vagina, the rectum away from the back wall, and we lay a very lightweight piece of mesh to the front wall of the vagina, the back wall of the vagina. And if you're keeping the uterus, the back of the uterus, if you're not keeping the uterus, the top of the vagina. And the mesh exposure rates of using mesh for prolapse laparoscopically are very different than using mesh vaginally because we don't have an incision in the vagina that's sitting next to the mesh. So different.
Which PAMF are you located in?
I'm in Mountain View, but I have an office in San Jose and an office at El Camino Mountain View. But we have 3 of us that are trying to sort of help the entire area. So I carry privileges at most of our hospitals, but the office space is Mountain View in San Jose.
Yes.
Awesome.
Can we have your telephone number?
Oh yeah, yeah. I will. I'll share that with you. Yeah.
Thank you.
Awesome. So,
Babita, I'm sorry, I have a question. This is Padma Srinivasan.
Yeah.
Is the prolapse a causative reason for urgent incontinence?
So it depends. I just put myself a number down. Prolapse can be a cause for urgent incontinence if they're not emptying well. So when patients come in with prolapse or with urgent incontinence, we screen for prolapse and we screen for a post-void residual to see how they're emptying. But if they're prolapse, so if you have a significant uterine prolapse or a significant cystocele, it will kink the urethra and people won't empty very well. And if they're not emptying very well, they end up with symptoms of urge incontinence because their bladder is constantly contracting with that elevated volume. So if you can correct their prolapse 50% of the time, urgency and urge incontinence improves. I don't guarantee that usually because it could be intrinsic to the bladder muscle itself, but for the majority of time, if they have an elevated post-void residual, if you improve their prolapse, urge incontinence improves. Sometimes I will actually tell patients, try a pessary. See if we can get you to use a pessary. And if your urge incontinence improves with a pessary, that's the surgical outcome I'm going to mimic. And that will then tell me that their urge incontinence probably will improve because I hate to give patients expectations if that's not what's going to be the outcome of the surgical outcome. But a lot of those guys will try a pessary trial. They'll empty better. Their urge will get better. And then we'll fix their prolapse.
Thank you.
Yeah. Yeah, and feel free to reach out to me via my cell anytime. Happy to help or discuss any patients that you guys may have.
awesome. Any more questions from our members to the esteemed speakers?
Great talk. Thank you very much.
Yeah, very nice
Perfect.
talk.
So thank you so much for the wonderful presentation this evening on diseases of the prostate and other common urological complaints in men, Raj. And Savita, that was a brilliant talk on types of urinary incontinence and pelvic organ prolapse, a very common malady that affects 1 in 2 women. So we are very grateful for your work in the field of urogynecology. Godspeed. And we have learned a lot from both of you, and Apio is very grateful for your time and presentation this evening. We are very proud that our Indian American physicians are making great strides and doing all this amazing work. We're very proud of you. And we look forward to having you join us again in the near future for continued education in urological topics. And please join us, in RPO as members, and we look forward to having you share your expertise and energy and drive our organization forward too.
Thank you. Thank you so much for the opportunity.
Thank you again for the
Thanks a
invitation
lot.
and your time. Appreciate it. Nice meeting you all.
Thank you.
Please, we
Your
need the
patience-
telephone number.
Yeah.
And just a quick word for members who are interested in, accessing the slide deck. Please contact Dr. Raj Shingal directly for, if you want his slides. And Dr. Savita Krishnan is okay with me sharing it, so I can share it with through email for members who are interested.
Thank you.
Thank you.
Thank
Thank you
you.
all. Have a good night.
Thank you.
Thank you.
Thanks.
Good night.
Good night.
Good night.
Good night.